Good evening. I think in today's session on the platform of Organization for Rare Diseases, we would like to thank the ORDI for the opportunity to speak on a very important rare disease on hereditary angioedema. Before we start the session, I would like to call upon Dr. Anika Bellard, who is a physician scientist and a clinical biochemist who works mainly in multi-omics research in rare genetic disorders. She would be moderating the session today. And Dr. Anika has finished her master's in MD in biochemistry from the Karnataka Institute of Medical Sciences, Hubli, post which she has pursued her PhD in molecular medicine from the Institute of Bioinformatics and Maha University. She is currently a faculty scientist at the Institute of Bioinformatics, Bangalore, and an adjunct faculty at the Manipal Academy of Higher Education. And she has served as a visiting scientist in the Department of Laboratory Medicine and Pathology at Mayo Clinic, Rochester, Minnesota, USA. Over to you, Dr. Anika.
Thank you, Dr. Sowmya. It's a pleasure to introduce you as a speaker today. Good evening, everyone. It's my pleasure to be a part of Rare Info Series conducted from ORDI, and I sincerely thank ORDI and the organizers for giving me this opportunity to moderate today's session, which is on the important, under-recognized, yet which deeply impacts the patient lives. So today's session is on hereditary angioedema, uncovered insights and innovations for better living, which will focus on improving awareness, early diagnosis, and evolving management strategies for hereditary angioedema, an area where timely recognition and appropriate care can significantly transform quality of life. So to speak on this session, we have today Dr. Sowmya Nagarajan, who is a consultant pediatrician, allergist, and an immunologist with extensive training nationally and internationally from Singapore and UK. She graduated in medicine from Siddhartha Medical College, Tumkur, Karnataka, and pursued her post-graduation in pediatrics from MS Ramaya Medical College, Bangalore. Post which, pursuing her interest in allergy and immunology, she worked as a clinical fellow in the prestigious National University Hospitals, Singapore. She has also completed her diploma in allergy and asthma from the reputed College of Christian Medical College, Vellore, India. She did a fellowship from St. James Hospital, Leeds, UK, as a part of JM grant from European Academy of Allergy and Clinical Immunology. She is among the few European Academy Allergy and Clinical Immunology board certified specialists, as well as a fellow in the American Academy of Allergy, Asthma, and Immunology. And she pursued her diplomate in systematic reviews and meta-analysis from Johns Hopkins University. Currently, she's a practicing pediatrician, allergist, and immunologist in Sanjeevini Hospital, Motherhood Hospitals, and Allergy Central in Bangalore. She is deeply involved in clinical care, academics, and training, having mentored over 200 medical professionals in allergy and immunology. Her clinical interests span airway and skin allergies, food and drug allergies, primary immunodeficiencies, and advanced therapies, including oral immunotherapy. She is also a strong advocate for patient and parent support initiatives. With her extensive clinical experience and academic leadership, we are confident that this session will offer a valuable insights on the hereditary angioedema for all of us. So I now invite Dr. Sowmya to take over us through the day. And over to you, Dr.
Thank you,
Sowmya.
Dr. Anika. Thank you for a very kind introduction. And as you rightly said, I would like to thank the organizers and ORDI for giving us this platform to deliberate on rare diseases, and hereditary angioedema is one among them. So going forward, I think today's session will be mainly how we can improvise recognition, diagnosis, and access to medications or the treatment options for patients with hereditary angioedema. Starting off with one of our patient, this was a 20-year-old young girl who comes from rural Karnataka, history of recurrent episodes of swelling of eyes, lips, and hands. And she's been having this episode since she was about 13 years of age. And she says that sometimes it's more during her menstrual periods. She also says that she has some vague rash which is not itchy. Whenever she goes, the nearest hospital is the district hospital or the nearest medical college. She's been given IV Avil, which is an IV antihistamine, and a IV steroid, dexamethasone, each time she goes with minimal or no relief immediately. But she has been going through this episodes in the last few years. On probing, the mother had similar histories, episodes in the past. However, the father is healthy. She has a younger sibling of 6 years who has no history of atopy or similar complaints. The question is, she has gone to many doctors and she is struggling to get an answer for her diagnosis and how to proceed the way forward. So, on the right hand side is the image where such episodes happen in the patient we saw, and similarly, we have patients who just present with the edema of the hands, lips, or fingers. On the left side of the screen is the patient where we have raised rashes which are quite itchy, and this can be associated with the swelling, but not as much as this. In patients who present with only swelling, that's on the right side of the screen, picture number 2, they wouldn't have any itchy rash. So the overlap condition is the picture 1 is urticaria with angioedema. This is one. And this picture number 2 is only angioedema of the hands. So how is it different, and what should we be keeping ourselves open when we are seeing this patient in clinical practice? Because angioedema can occur in patients with urticaria in at least 20% of patients with acute urticaria and at least 40% of patients with chronic urticaria. So in urticaria, the hallmark feature is itchy rash, and it occurs secondary to infections, foods, drugs, insect bite. But infections by far is the most commonest cause of acute urticaria, which is hallmark of itchy rash. And it lasts for 6 to 8 weeks, and it is self-limiting beyond that, especially if it is infections. On the other hand of the spectrum, chronic urticaria, where the itchy rashes persist beyond 6 to 8 weeks after the presentation, we label it as chronic urticaria, and here angioedema presentation we see in at least 40% of the patients. Here we have inducible urticarias, autoimmune, spontaneous urticaria, which is beyond the scope of today's discussion. So how do urticaria and angioedema differ, even if they coexist? It's very important to understand that angioedema involves a deeper layer of the skin or the subcutaneous or the underlying skin of the underlying tissue of the skin or the inner laying of the organs such as the mouth or the gut. Whereas urticaria is just involving superficial layer of only the skin. Mucosal involvement is involved mainly in angioedema. Urticaria, as I was telling, pruritus, itching is very predominant complaint, which is conspicuously absent in angioedema. Okay. Pain and tenderness are uncommon in urticaria. We may see that more in angioedema. So unless if it is an itchy rash which is not present, we must be thinking of angioedema alone. Angioedema, it is mainly the localized swelling of the skin or mucosal tissue due to extravasation of fluid into the interstitium. Very predominantly, it occurs in non-dependent areas such as face, lips, tongue, throat, larynx, genitalia, sometimes abdominal wall. It is asymmetric, that meaning it is not present on both the parts of the body, and it is non-pitting edema. On the other spectrum, where we see which is involving the dependent areas of the body, such as the ankles, feet, where we see pitting edema, secondary to the hypertension or glossitis, or when you are sleeping on one side, swelling of the face. So here that is not angioedema because it could be symmetrical and it is occurring in the dependent areas. Angioedema is important because here we see only swelling of that particular organ involved. Here in the picture, we are seeing angioedema of the lips, conspicuously absent with hives or urticaria. Just a brief slide before we go on to the hereditary angioedema, because many a time we have seen that patients who present with hereditary angioedema, like our patient, has been treated with antihistamines without much relief. So it's important to understand the difference between bradykinin and histamine-mediated angioedema. In histamine-mediated, where it is urticaria and angioedema, we see it is associated with exposure to the allergens such as foods, drugs, or insect bite. The swelling subsides within 24 hours after the onset without leaving any mark. and it responds very well to our oral or IV antihistamines or steroid therapy. On the other end, bradykinin mediated is not associated with urticaria, not having any history on exposure to allergen. Angioedema the resolution can take up to few days, and conspicuously, they do not respond very well to antihistamines or corticosteroid therapy. Coming to the types of bradykinin mediated angioedema, now that we have understood it is different from urticaria mediated angioedema. The different types we know that are ACE inhibitor induced angioedema, hereditary angioedema, which is mainly genetic in nature, and acquired C1 inhibitor deficiency. Idiopathic angioedema also where we do not have any explanation, which do not fit into these above categories, can be histamine or bradykinin mediated angioedema. So today's scope, we will be discussing mainly on the hereditary angioedema and not go much into the other types of bradykinin mediated angioedema. Hereditary angioedema is a rare and potentially life-threatening condition. Predominantly, we see this with a enzyme which is involved in our body called C1 inhibitor, which is deficient, meaning it is not present in good quantities, or if it is present, it is not functioning adequately. The condition, we would come to the types, but which is involved with C1 inhibitor deficiency per se, where it is not present in normal amount, is autosomal dominant. The worldwide prevalence is about 1 in 10,000 to 1 in 50,000, with a more female preponderance. We see this condition being under-recognized, leading to the delay in the diagnosis, leading to up to at least about easily 8 to 10 years from the onset until the patient is actually diagnosed, leading on to inappropriate treatment, especially with antihistamines and glucocorticoids. Family history may be present like in our index patient, but some of the patients, the mutations may be happening, new mutations where the family history may not be present. So basically, these autosomal dominant mutations basically happens because of the mutations in the gene which codes for the C1 inhibitor enzyme, SERPING1 gene. And because the C1 inhibitor is important in the production or the regulation of the bradykinin pathway, which is the key mediator of angioedema. So as I was telling, worldwide preponderance is about 1 in 50,000. But in India, I think in the recent years, because of the increasing awareness and the number of centers which are offering diagnosis and management to these patients, we are seeing at least prevalent more than 30,000 patients. If we calculate this according to our population, more than 30,000 patients suffer from hereditary angioedema. And there are a lot of other patients who are still underdiagnosed because of the lack of awareness or the access to the diagnostic facilities in our country. Why are we more worried about HAE attacks if it is only just causing the swelling of hands, lips, otherwise? It is not just the angioedema which is the main causative factor, because this attacks can happen impromptu without any awareness or when it is going to happen. Attacks can be disfiguring, disabling, and it can affect the quality of life of the patients because it takes few days to resolve on its own. And without treatment, there is a mortality. That means death can happen in at least 30% of the patients, because if the angioedema occurs on the vocal cords, it may, or where we breathe, this may lead on to breathing difficulty and death if it is not recognized. The type of attacks could be facial, laryngeal, abdominal, urogenital, or the extremities, which can happen. The mainly, I think the average delay in the diagnosis. Sorry about that. The average delay happens at least 10 years from the onset, mainly because We do not know what we are treating. We think it is urticaria. We just end up giving antihistamines and steroids. And if there is abdominal symptoms, we may just tell that it could be just functional abdominal pain, or this could be happening in the uh, recurrent or functional abdominal pain, and we may actually treat them as acute abdomen, such as appendicitis or surgical intervention, and they may unnecessarily undergo surgical procedures which may be unwarranted. So this is asymmetric, non-pruritic disfiguring without urticaria, and we saw which may be involving different parts of the body. Mainly, I think we are mainly worried about the vocal cord angioedema, which can lead on to breathing difficulty, and if not appropriately managed, this could be fatal as well. Though total episodes of laryngeal angioedema can account for only less than 1%, but in patients with hereditary angioedema, more than 50% of the patients sometime would have had one episode of laryngeal angioedema, and actually this can be the initial presentation. And as we see, few of our patients have had abdominal attack manifestations with severe abdominal pain, can mimic acute abdomen. Even on ultrasound, we may just get bowel wall edema with circumferential thickening of the bowel wall with or without ascites and no lymphadenopathy. So we call something called a prodromal symptom. The angioedema can be prognosticated when is the patient actually having angioedema. So it can sometimes in some patients we get a history that a snake-like kind of non-pruritic rash, which is not to be confused with urticaria, which we were discussing in our earlier slides. This is non-pruritic, and this can start a few days before the onset of the angioedema in 1/3 of our patient, and they get this tingling, numbing sensation at the swelling site, which could be starting. And triggers are many. It could be estrogen supplements, infections, AC inhibitors, trauma. Sometimes dental procedure can itself trigger of angioedema, stress, frequent travel, lack of sleep. So this can be the few triggers which can happen. Just a bit on acquired inhibitor angioedema, because they occur very similar to the presentation of hereditary angioedema, but this occurs because of the acquired deficiency in the C1 inhibitor, C1 esterase inhibitor. This is not as common as we see in hereditary angioedema, which could be earlier presentation in the adolescent or in the young adults. We have had children who have presented in by about 5 to 7 years of age also. On the other hand, acquired C1 inhibitor deficiency could be the onset we see 40 years and above, and underlying medical conditions such as lymphoproliferative disorders, malignancies, or autoimmune disorders. So the age of presentation and underlying medical issues could differentiate between the presentation secondary to hereditary angioedema and acquired C1 esterase inhibitor deficiency. So, what is the pathophysiology of hereditary angioedema? This is important to understand because this is where also the management is also important. Basically, the C1 inhibitor, esterase inhibitor, has a regulating effect mainly on the bradykinin pathway, where it is important for the prekallikrein to be converted into kallikrein, and thereby the kallikrein is converted into bradykinin under the influence of C1 esterase inhibitor and the presence of high molecular weight kininogen. If there is a deficiency of the C1 esterase inhibitor, or if it is present in adequate quantities but not functioning properly, it leads on to the unregulated bradykinin pathway, which leads on to vasodilation, increased vascular permeability, and pain. Basically, leading on to the increased vascular permeability, plasma leaks happening into the surrounding tissue of that mucosa or the skin, causing edema. So in bradykinin mediated angioedema, and especially in hereditary angioedema, there is absence of urticaria and it is only the presence of edema in the submucosal tissues or the subcutaneous tissues, which also may have pain or tingling sensation because it is bradykinin mediated. Again, we have covered the triggers, mainly the trauma, stress, medications, infections, menstruation. Even these patients, if they have a small injury, say a thorn prick or a pin prick, that self, it can be a trigger for the attack of the angioedema episode being happening. It is important also to emphasize the diagnosis of hereditary angioedema, because even in few of our patients, my patients, a family of the mother and the son, they presented with acute abdomen, and the son has undergone appendicectomy and an acute abdomen the abdominal exploration surgery because of the intensity of the pain he presented with. So I think it is important that we have a high index of suspicion, especially patients who present only with hereditary angioedema. And how can we help these patients get managed further on? So it is important to understand there are two types of, maybe three types of angioedema, but we would keep this for discussion purpose simpler: type 1 and type 2. Type 1, we have C1 esterase deficiency, which is characterized by low antigenic and functional levels of C1 esterase inhibitor levels, which predominantly make up the major chunk of patients who present with hereditary angioedema. Type 2, where the C1 esterase inhibitor is present normally. If I do the levels of C1 esterase INH levels, it would come back normal. Sometimes we also have a subtle marker that it may be a slightly elevated. But if I do a functional assay, whether it is functioning properly to regulate that bradykinin pathway, what we saw, it would not be functioning adequately. So whenever you have a patient presenting only with angioedema, we suggest doing C4 levels. This is poor man's screening method for hereditary angioedema, because most of our patients, when we see with type 1 or type 2 hereditary angioedema, we see with low complement C4 levels being presenting. So where we do not have much access to the functional assays or the advanced test, I think just doing a C4 and a C1 INH levels would be helpful to know whether we are dealing with patients with hereditary angioedema. So definitely in type 1 and type 2, the C4 levels would be less. And in type 1 hereditary angioedema, we could have low C1 INH level. And also, if we do a functional assay, which may not be very commonly available, but that would help us differentiate between type 1 and type 2, though the treatment remains the same, just to label them. And in type 2 hereditary angioedema, we could have normal or high C1 INH levels, but definitely the complement level C4 would be reduced. In a small subset of patients where we have patients presenting with angioedema alone, they could have normal C1 INH and normal functional assays with normal C4. So that is beyond the scope of today's discussion. But if we have any patient who have presenting with angioedema alone, do a C4 level and a C1 INH level, and still the degree of suspicion is high, and then they could be referred, or we could do a C1 INH functional assays. So most of the guidelines, this is taken from our Indian guidelines, which has come out from the PGI Chandigarh, where a lot of work has begun for HAE, and the access for treatment also. That is one of the pioneer institutes which has guided the access to the management for patients with hereditary angioedema. So if we are having patients with suspected hereditary angioedema, where they are having recurrent episodes of angioedema without urticaria, or if they are presenting with recurrent abdominal pain without any definitive cause, and if there is a family member who is diagnosed to have HAE, we can do C4 levels, C1 INH levels, and C1 function assays. And if we have C4 low, with the C1 INH levels being low, function being low or normal, we can take them as type 1 hereditary angioedema. If the functional assays are low with C4 levels being low, then we take them as type 2 HAE. And HAE with normal C1 INH levels and functional being normal, we label them as HAE with these normal levels. So we manage them accordingly. If we are having patients with type 1 and type 2 HAE, we should be offering them gene sequencing for SERPING1 and family screening for at least for the first degree relatives. At present, we do not have much management of hereditary angioedema, and we have been managing these patients with hereditary angioedema mainly with tranexamic acid and steroids until few years back in India. Right now, we have approval for or FFP, which has been the long-standing management of patients with hereditary angioedema. Mainly, I think as we were talking about the pathophysiology, the C1 INH or the FFP, which has some amounts of C1 esterase inhibitor levels, can have a regulating feedback on the management, on the unregulated production of bradykinin by checking on the kallikrein pathway. That is one treatment option. The other treatment option, which are ecallantide or ecantiband, which are not available in India, and which has the other treatment options include tranexamic acid or steroids, androgens such as stanozolol or danazol, which do not address these other prior pathophysiology pathways, but has an indirect effect on the edema or on the pain receptors. So, ecantiband is a bradykinin B2 receptor inhibitor, and it is mainly given as subcutaneous injection, and which is not available in India, and as well as the plasma kallikrein inhibitor ecallantide, which is also a subcutaneous injection. Right now, we do not have access to this. Mainly, I think in India, we have been managing with FFP, tranexamic acids, and androgens, but they are not the standard of care for the reasons because in tranexamic acid, we have gastrointestinal manifestations. Rarely we have postural hypertension. And though we have been using tranexamic acid for a long time, we have not seen any patients with thrombosis. But the main limiting factor for long-term management with tranexamic acid, because this forms the this has been the main management, especially in female patients, because their androgens may not be used because of its adverse effect profile. The theoretical risk of this thrombosis is always there, and we have contraindications such as if there is previous history of thrombosis and any visual color vision acquired disturbances, hematuria, or other bleeding manifestations. We do not cannot use tranexamic acid in these patients. And androgens, though it is very good, and we cannot use this in patients, especially female patients. And we have seen that this has a side effect profile, especially ranging from weight gain, hirsutism, mood changes, insomnia, acne, menstrual irregularities, among others. So the recommendations across the guidelines, YAKI, the World Allergy Organizations, even our Indian guidelines, which say that recommendation for the C1 inhibitor concentrate as a first line long-term prophylaxis as well as on acute demand. And they recommend the usage of androgens only as second line long-term prophylaxis where the access to this C1 esterase inhibitor concentrate is not available. This is also found to be quite used safe in pediatric population under 12 years of age also. And it is also the C1 inhibitor concentrate can be used safely even in pregnant women and breastfeeding women also without much effect on the outcome in the breastfeeding children or the patients per se. So our patient who had this presenting complaint, she we proceeded to do a C4 levels which were low. We also did a C1 esterase inhibitor where we saw that her levels were definitely less as compared to the reference range. We also did a functional assay which was less than the reference range in this young lady, and the gene mutation was also done where it was found that she was positive to that one of the SERPING1 gene mutations, which was predominantly autosomal dominant. And I think given that her mother also had similar history, this was autosomal dominant. And we also presented this two of our other patients. And I think this was mainly thanks to Dr. Harsha. These were his patients and we co-managed. This was a young gentleman who had history of recurrent episodes of acute abdomen and had history of angioedema of the peripheries as we see on the hand in the photo here. Sorry, this was for a poster we had put up. And this patient underwent appendicectomy and has undergone acute abdomen exploration. So, and on probing, I think this patient mother also had a similar onset, though the age of diagnosis was quite late when she was 61 years, but the age of onset was when she was 46 years. And this patient, young gentleman, had a history of symptoms from 29 years, and this patient was diagnosed at 37 years, which was very matching with the C4 levels and the C1 inhibitor levels. So I think it is important that this has been only presented few of our patients to sensitize that patients with angioedema alone who present is not rare because they do not present to one specialty per se. A pediatrician could be seeing this if it is a child who's presenting or an adolescent. An acute, the emergency physician could be seeing this patient if they are presenting with breathing difficulty. A surgeon could be seeing this patient if they present with acute abdomen. A gynecologist could be seeing this young women who present with menstrual irregularities or angioedema occurring around that time. Rheumatologist could be seeing this patients if they have other associated comorbidities, or a dermatologist could be seeing. So I think I may have missed few other specialties who could be seeing. General physician could be seeing these patients. So I think because hereditary angioedema is not limited to one specialty, the so it is not confined to one specialty. So that for us to raise the awareness, it is important for us to raise this awareness across specialties and give them where we have a high index of suspicion. We must give them screening tests, and especially if these patients who present with angioedema alone without urticaria, please do not give antihistamines or steroids. Kindly have a suspicion of bradykinin mediated angioedema, and among various other Presentations of bradykinin-mediated angioedema, hereditary angioedema must be definitely recognized. If it is an adult onset, please look for any concomitant medication intake such as AC inhibitors or estrogen containing medications like oral contraceptives if they are receiving. If you are having a high clinical suspicion, get a C4 level done. If it is in the periphery, if it is low, kindly refer them to centers where C1 inhibitor levels and functional assays can be done. HA management, though it is lifelong, we can give them a good quality of life where we can reduce the triggers, we can reduce the acute attacks and improve their quality of life. We can give them accessible on-demand treatment for acute attack for all patients, and when indicated, we can put them on prophylactic therapies. C1 esterase inhibitor concentrate remains the mainstay of treatment for hereditary angioedema, be it as on-demand and probably in future where patients can get access for their prophylactic therapy as well. Please bear in mind that antihistamines, epinephrine, especially if we are thinking about patients who are presenting with acute allergic reactions where breathing difficulty, we do not do them any harm in giving epinephrine. But if it's an acute allergic reaction such as anaphylaxis, epinephrine would definitely start helping in few minutes after an adrenaline shot is given. But if they're not responding, then I think we should definitely think about bradykinin-mediated angioedema and hereditary angioedema being the main chunk of angioedema. I think right now, the hereditary angioedema in the recent years, thanks to the efforts of various stakeholders in the creating the awareness of hereditary angioedema, such as the physician group, the HAE Society of India, the ORDI. I think at the patient advocate groups per se, which is very active in HAE, I think this has been thanks to the efforts of all the stakeholders. It is being covered by the Rare Disease Policy of India, and because it has been approved for use and because it's a life-threatening disease and it is lifelong, it is being provided to patients in centers of excellence. I think PGI Chandigarh, the blueprint for access to C1INH began with the center there. And um, it has formed the blueprint for the other screening, other centers across India, where the patients can register in the centers of excellence there. The nodal officers screen, and these are the few of the blood tests where it has to be done for the patient to be eligible to get C1 esterase inhibitor. And recently, we had a roundtable meeting regarding the same in Bangalore, and I think where it was very enlightening or enriching to hear that other nodal centers are screening and they have started indenting their C1 esterase inhibitor for these patients. We are awaiting the same in Karnataka as well, hoping that the patients here would be able to get access to C1 inhibitor esterase also, which can be self-administered with good patient education if it is happening immediately, and then they can come to the hospital for monitoring. So I think taking this platform as reaching out to most of my physician colleagues across India and patient support groups as well as patients, we would request to create more awareness among the population for hereditary angioedema, because we are still not diagnosing much for these patients. And we should be able to get access for these patients for the treatment under the aegis of the Rare Disease Policy of India. Again, at the outset, I would like to thank the ORDI for giving us an opportunity to discuss this very important topic. And I hope this helps us in the way forward for getting more patient easy access for diagnosis and management. Thank you.
Thank you, Dr. Sowmya, for an extensive talk and giving the awareness among the physicians and the community to understand this, though a rare disease, but yet not still so rare as other diseases, and how important it is to diagnose early because it's a life-threatening condition at some point. So we will take questions. I would request all the participants to put their questions on the Q&A chat. So before that, I have a couple of questions, Dr. Sowmya, to you.
Yes, Dr. Anika, please.
Yeah. So is like, as you mentioned, it can have a precipitating factors and surges. So is it, are there surge of attacks, or is pregnancy a precipitating factor for HAE?
Definitely, because pregnancy per se, because there is a lot of hormonal surge which is happening. So we do see patients, especially when they conceive or during the pregnancy, also to have probably an increased the angioedema attacks, what we call, or the exacerbations. We see this, and also in young females, especially during the time of the menstruation, or if young females who are married or who are on oral contraceptive pills or who are on OCPs or other estrogen containing medications, we see that around this, when they are on these medications or around this time, the patients are more prone to have the angioedema exacerbations.
So they can be mild, and first time only they can present during
Definitely,
pregnancy.
definitely. So as I was telling, it may be the first time a gynecologist or an obstetrician could be seeing this patient with an angioedema episode. So definitely it is not limited to any one specialty at all. ER people see physicians, see dermatologists, rheumatologists, allergists, pediatricians, surgeons. I may have missed few other specialties, but I think we have seen patients who have been referred, who have gone through this n number of specialists, but still, unfortunately, the diagnosis has been missed.
So do you feel, because the diagnosis is still challenging sometimes, do you think is there a role of genetic testing in all suspected cases of HAE or any specific scenarios?
Definitely. I think in a low resource setting country like ours, I think now genetic testing for suspected patients may be a little far-fetched, but I think C4, which doesn't cost much, and most of the labs do C4 complement 4 levels, and it doesn't cost more than few hundred rupees. I think whenever we have patient presenting with angioedema alone, we can do C4 levels. And as I was mentioning earlier, in our patients with type 1 or type 2 HAE, most of the times we would have low C4 levels. And then if we have access to getting a C1 inhibitor esterase levels done, we can do it, or we can refer them to a tertiary center where the access for this test can be done. But C4 levels, even if you're suspecting, you can do it at any peripheral center because most of the labs, medical colleges, district hospitals, all the private labs do have access to C4, and it is not very expensive. So, but only in patients who have been confirmed with we are suspecting with hereditary angioedema, where the C1, the levels of the C1 INH are low, or if it is normal or a little higher, and then we do a functional assay if it is low, then we send in for the genetic testing. Otherwise, I think definitely C4 any one of us can do, and we can suspect. And if we are having a high index of suspicion, we can refer them for further diagnosis and management accordingly.
So considering this a rare disease, and people may not even like sometimes suspect it as an HAE, like how many, like what are the clinics, specialty clinics where it is inaccessible to people, and like how many are there in a
Oh,
region,
okay.
or like
So I
people
think, yes,
who are
definitely.
trained? Yeah.
For trained, yes.
Yeah.
I think in the recent years, the awareness among HAE is definitely much better. Be it across, I think there are, especially talking about few centers across India, PGI, as I said, It's one of the pioneer centers under Dr. Sujit Singh, Dr. Ankur Jindal, and the dermatology department, which has taken up this in a very big sense. Uh, there are other tertiary centers in India. In Karnataka, we have private centers such as Manipal, Aster, or Mallige hospitals, or the Indira Gandhi Institute of Child Health in Bangalore, where access we can try to refer them, and they could get the testing done. Other states, we have other nodal centers which can give access to the diagnosis or the management. I think if they connect with ORDI or any other specialists who are doing training, I think who have been trained, definitely the patients can be managed. Having said that, I think the emphasis on the hereditary angioedema or the angioedema in our medical curriculum, because this is so rare, I think this gets a brief mention in our textbooks, be it at the
Yes.
undergraduate level or at the postgraduate level, because infectious diseases form
Yes.
the crux of the problem in our country, because that is, we are grilled and trained to identify
Yeah.
infections. Because this is a rare disease, I think the mention is much less, and that is why it's not that the lack of the
Mm.
knowledge or not. We would know it, but we wouldn't give much importance
Yes.
to it because we are more concentrating on the other
Yeah.
important aspects of infections. I think that's where we have not given much emphasis to this diagnosis. In the recent past, I think because of a lot of academic initiatives across specialities and patient support groups, we have had increasing awareness among different specialities.
So I believe there are a lot of clinical trials which might be going on this treatment, right?
Definitely.
So how are they? How do you monitor post therapy? Like, is it just the clinical improvement, or any markers do you have?
Biomarkers to see whether they are responding. Generally, we do not rely much on the improvement in the C1 inhibitor levels or the
Yeah.
functional assays. It is only the clinical management generally. And there are a lot of upcoming, even the two drugs I mentioned. Beyond that, I think there is a lot of clinical trials happening across the world, where even from the injectables, we are coming down to the oral medications, which is much more easier, safer, and accessible for the patients. I think, given that we did not have access to one of the most first line medications which was recommended in the last few years, we have access to it, and that has changed the scenario how we can approach the patients with HAE, rather than just giving them with fresh frozen plasma or tranexamic acid or androgens, which is still the mainstay of treatment, because the C1 inhibitor concentrate is a little expensive and not accessible to all in the private sector also. That's where, because it is being brought under the Ages of Rare Disease policy of India, patients are starting to get access to it. I'm sure in the next few years, I think we would have access to other medications also.
Yeah, I do not see any questions in the Q&A still.
Sure.
So, like, this is a very unpredictable surge sometimes, and there would be a lot of psychological impact, I believe. So, do you see such cases?
Definitely. That's an important question. I actually wanted to highlight on that because, say, one of our patients, they would be sitting in a meeting and they would start getting this angioedema attack. It may be the lip or eye swelling, which can be disfiguring. And that affects their um, confidence in how they
Mhm.
present themselves. Or it could be an acute abdominal attack, which they cannot explain, but they say that they are suffering. When they try to explain it to the attending physicians or the healthcare, I must not say physicians, the healthcare professionals across specialities, or their family members or peers, sometimes they are not taken seriously, especially if it is the abdominal attacks. And over a period of time, because there is a delay in the diagnosis, it affects their quality of life and their self confidence, affecting very badly. And sometimes we may have to take the help of counseling also to help them understand, come to terms with their diagnosis and how they can manage. But I think with um, good, effective, if we give a diagnosis, they have a name for their presenting symptoms. And people would be more reciprocative when they present to any hospital with their diagnosis, then they have also have an answer for what they could be done. So I think we do see patients who their confidence, their self-esteem being affected, and because there is a delay in the diagnosis also. I think I hope in the next few years, with forums like this and many stakeholders getting awareness, the things would be better for patients with HAE.
So do you think there are a lot of research gaps in this area where we can work on being academician? Yeah.
Definitely. I think it's not that we do not have patients with HAE. I think we are not diagnosing them. And I think where India has a lot of potential, we are seeing research across other specialities
Yeah.
and biosimilars which are being produced in India, which grossly definitely brings down the cost of the treatment, especially in oncology or other fields. I
Yes.
think HAE is also one field where we are having lacunae in the research. I think if we
In-house
admit,
therapies and other
definitely,
things.
definitely, I think immunotherapies or other gene modifications or other treatment options in the pathophysiology, if we explore and if we can get clinical trials, I think definitely the patients would definitely benefit out of it.
So I have one last question. So how do you manage when they have with comorbidities like similar autoimmune disorders and other cardiovascular disorders where because
Um,
with these inhibitors, do they affect?
No, generally not. And these are usually quite safe
Mm-hmm.
across other comorbidities also. And especially if they have other autoimmune diseases or it may be acquired C1 inhibitor, that time the threshold for our management is a little more than the patients with hereditary angioedema because they'll be a little older patients. But otherwise, other cardiovascular, hypertensive, or other thyroid or diabetes, they do not have any, the management does not have any much change. Though we tell them to keep their other comorbidities well under check, because if we do not treat those comorbidities, that can itself act as a trigger for these angioedema attacks. So I think otherwise, um, the first line management has been found to be quite effective in patients who are pregnant, breastfeeding, in
Mm.
children as well. So it has been approved for use above even children less than 12 years, and is recommended in other guidelines across the world as well. It's just that when we have a patients with hereditary angioedema, I think we have to educate them about the triggers, how to best manage it, and educate them about the administration of C1-INH, where they can get it. If not, if we are putting them on other alternative managements, frequent follow-ups to address whatever gaps they are having. A written, we say, angioedema action plan. We write it to them that this is their diagnosis. If they're having an angioedema attack, they can go to with that action plan, which has the C1 inhibitor concentrate. If they have access to it, they can be given, or if FFP needs to be given. We say that minimal role of antihistamines or steroids. And I think if the patient has this access to this, and the person who is overseeing and access to them also, they with the collaboration between the healthcare professionals, the management of patients with hereditary angioedema becomes much more streamlined.
I think I have one question in the Q&A. I'm not sure if I understand. Is there anything positive of HAE? I don't know if that.
I think if they're asking for the investigations, as we said, C4 could be taken as one of the screening tests, and then we can do C1 INH levels, and if needed, functional assays also. I think based on this, we come to a diagnosis of hereditary angioedema. Genetic mutations, maybe the positivity may be maybe one of the prerequisites for patients who are acquiring C1 inhibitor from the centers of excellence or the under the rare disease policy, but that is not mandatory for patients to be labeled as hereditary angioedema.
Thank you so much, Dr. Sowmya, for your extensive and patiently answering the questions. And it was great to know you. Probably I would connect with you for any research studies
Definitely.
on this. Thank you so much for being
Thank you,
with
Dr.
us
Anika.
today.
Thank you.
Thank
Thank you
you.
for very
Thank you, Adi.
meaningful questions, which I hope would have addressed these concerns. And again, I would like to thank ORDI for taking up this important topic for discussion and hoping that this would help forward for our patients with HE. Thank you.
Thank you, Adi. Thank you.
Thank you. Thank you. Thank you.